I think we can officially start our today's online seminar. I would like to very warm welcome all of you to our today's OCULUS online seminar, which is called My Dry Routine, fast, non-contact, and patient-friendly. Therefore, I'm really glad that we can introduce you our panelists. At first, this is Sebastian Marks from JENVIS Research. We are working really close together for development of new structures, new themes, and theme of dry eye. And he's CEO and leader of the JENVIS Dry Eye JENVIS Research Center, working together with the well-known Wolfgang Sickenberger, optometrist. And on the other hand side, I am really glad that we have the first time working together with you, Brian Tompkins and Keyur Patel from Tompkins and Knight Optometrists, located in UK, Northampton. And they are, I just grabbed some points. They are the awarded for the technology practice of the year 2019. And luckily I had some photos of them to see what they are having. And I'm really looking forward that you guys are working with the K5 in terms of checking the dry eye stuff. And so far, I think we are running into a very interesting online seminar for that day. And at first, I wanted to show you what the K5, especially the dry eye stuff, is doing. And therefore, we can have a short introduction video. So let's play that.
Thanks a lot for organizing this webinar today, together with Brian and his colleague Keyur. And I would be happy to make the first introductory part to give a little bit an overview of why and how we developed the dry eye report. And first of all, for some people who don't know where we are, who we are, please allow me to briefly introduce me and respectively JENVIS Research. JENVIS is based in the city Jena, which is situated between Frankfurt and Berlin, as well as between Hamburg and Munich, so it's quite well centered in Germany. It is located in a valley. It has a very great history in optics, well known by names like Carl Zeiss, Ernst Abbe, and the famous material glass producer Otto Schott. The JENVIS Research Group is an independent group based at the Ernst Abbe University, established by two persons actually, Wolfgang Sickenberger and me. The main research competence includes clinical study and lab studies in the field of contact lenses, IOLs, spectacle lenses, and dry eye. The last topic, dry eye topic, seems to be getting more and more interesting, increasing awareness within the German practitioners. although this is not really a new topic. Already 100 years ago, dry eye tests were developed, like today, for example, by the German ophthalmologist Schirmer, and this test is still, till today, used beside a big variety of other modern test possibilities. Global ongoing dry eye research was and is conducted, and organizations like the TIFOS try to summarize new information and keep interested practitioners updated. The last version of the dry eye definition was made 3 years ago in 2017. So currently, dry eye is regarded as a multifactorial disease of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So as you did here right now, the definition is already quite complex, and the multiplicity of available tests is very huge. So years ago, Wolfgang Sickenberger had the idea to use, for example, ring reflections and other possibilities which are incorporated in a topography device to perform a dry eye investigation. This seems to be a quite simple but revolutionary idea, and that was interesting for many practitioners, as they can educate their patients much better using the keratograph, which offers a very good visualization of how the tears break up dynamically, for example. However, there was the need to summarize the measurement results in order to quantify if the patient's eye is this dry or that dry. So Wolfgang suggested to create a report which should be so simple that a patient can take this report home. The first practitioner who tested this initial report was Claudio Jäger from Switzerland, and who was already in Switzerland knows that the Swiss customers have a very high demand regarding high-level service. So they are willing to pay a high fee, but they are also requesting high-level service. So actually, Claudio was able to visualize the performed services in his practice much better in an affordable investment of chair time. And this investigation was conducted in 2014, and a little bit surprising for us, as this work is just considered as applied sciences and not rocket science. The JENVIS Dry Eye Report was rated among the top 10 innovations in the field of ophthalmology in the year 2015. This was a great honor for our team and for people who are involved in the project. So this first version of the JENVIS Dry Eye Report, the classic report, primarily summarized the results on a single page using well-known color coding and an easy-to-understand graphic which contains information is the finding good or maybe conspicuous. It was possible to either load existing results or to capture new measurements directly from that page. However, for users with a high patient frequency, there was potential for improvements concerning the workflow, which I will describe a bit later. In order to be up to date today, a lot of leading optometrists orientate at publications made by the TIFOS reports. And one of these publications you see here partly, this scientific graphic, like this one, for example, try to summarize the way how a dry eye diagnosis should be conducted. But what remains if we want to bring this into practice? Right now, optometrists or ophthalmologists would understand this graphic on the first view. I think not all of them would understand it quite well in a few moments. So this is my simplification. Capturing of patient history is a must, of course, and evaluation of risk factors can be very important for the later therapeutic options. And yes, contact lenses, unfortunately, but also drugs, smoking, display work seems to be beside the age important factors. a diagnostic test battery follows typically, and this analyzes, and the type of the test depends on their availability in every practice and the training of the staff, of course. However, in the end, it should be the target to find out the type of dry eye, as the therapy options may differ. So how can we implement this into the typical optometric customer journey? So the implementation of dry eye diagnostics can be very beneficial for every optometric practice. When we look to the classic way how a customer comes in and the way how the different examination steps are proceeded, we see several time points where the use of the keratograph 5 can be beneficial. So very often the assessment of patient needs show already hints of the tear film problems. That's why a tear film screening should be a part of every refraction, ideally prior capturing objective autorefraction or wavefront values, which might be even better after applying artificial tears. So in about 30% of the cases, we will see indications of dry eye in a just normal patient population. And it would make sense to offer them a complete dry eye diagnostic test for them. So this enables the practitioner to offer follow-up visits, like in the field of contact lenses, for example, beside the sales of glasses, additional sales of artificial tears or heat masks or whatever, supplemental food. This type of service is going to be paid, is understandable for the patient, and with a chance of differentiation to online businesses, which is more and more important for the offline stores today. So what is actually needed, depending on the frequency and type of patients coming to your practice, the training level of the staff, the availability of diagnostic tests, and practice-dependent standard workflow is needed, which might be customizable from time to time, depending on the patient. And this workflow should be time efficient, including the documentation time, allowing the practitioner to interact more with the patient than with the diagnostic tests. So this is very important when it comes to the therapeutic options or suggestions to improve the compliance rate. The mentioned points can be supported by the new JENVIS Pro Dry Eye report, which is actually a kind of software module which comes together with the OCULUS K5, and then it consists of 3 diagnostic workflows, depending at which point of the patient journey it will be applied. So most of the single measurements can directly conducted by the use of the OCULUS K5, meaning an instant documentation with no waste of time. So at the beginning, you can optionally choose to use the screening module as an initial short investigation if a dry eye is indicated or not. This initial test should take no longer than 5 minutes. If we find indications for dry eye, which is typically in around 30% of the cases happening, the main workflow of the dry eye diagnostic with the JENVIS Pro is called TF, or tear film individual, and it consists of a well thought through workflow regarding time efficiency and invasiveness of tests. It delivers finally a good overview about the dry eye status, allowing the practitioner to make rational recommendations towards the patient. The success of every treatment can be checked by the follow-up workflow after a specific treatment time. So the follow-up workflow is like the screening workflow, it is reduced to a few selected tests which are performed prior to treatment in order to give us as practitioners the opportunity to compare the results. But how is the workflow of these modules actually working? And this is a little bit special. So typically what we are doing historically is to perform a test and to evaluate the test results and document them immediately. As the JENVIS Pro Dry Eye report is using the options of the Cartograph 5, and there is not all the time it's not all the time necessary to switch the diagnostic instrument, the most of the time. So it is good to structure the routine into two parts, a so-called capture session and subsequent an assessment session. The capture session provides illustrated information, which measurement steps should be done, shows forthcoming steps, and is optimized to avoid too many right eye, left eye changings. The assessment session, on the other hand side, once the capture session is complete, the assessment session starts, in which the conducted measurements will be analyzed, some of them even automatically, like the evaluation of the redness of the bulbar conjunctiva or the limbal conjunctiva part. This is done automatically. Other assessments need to be done by the practitioners themselves. And color coding, like in the first classic dry eye report, supports the easiness of understanding the results. This way, we can work most time efficient and have as much time as possible to really interact with the patient. Once all the measurements are done and analyzed, we have the option to mark. Let's see if I can show you this one. Okay. Here in this section, you can mark different sections for measurements, for example, tear film measurements, or the second part, lid margin measurements, or here conjunctival measurements. And those pop up as a potpourri of little pictures on the left-hand side. And the practitioner may jump into the single measurements and give the needed information for the patient to create more understanding, which is very important to get a compliant patient. So this combination of the Cartograph 5 with the JENVIS Pro Dry Eye report is a very strong tool for every practice which wants to deal with the dry eye very efficiently. And so at this point, I'm very happy that two fantastic practitioners from the UK, Brian Tompkins and Keyur Patel, are available today to discuss with me how they deal with the topic dry eye in their practice. And in addition, they will present some recent cases at the end of this webinar to demonstrate their experiences. And I'm pleased, or I'm in the pleasant situation to ask a few questions today. So at the beginning, I would please Brian and Keyur to briefly introduce themselves and their practice maybe. And I will hand over the screen sharing at this point to Brian.
Thank you, Sebastian. Or should I say, vielen Dank. It's a pleasure to be here. Guten Tag, everybody, or basically just hello. So typically for me, I can't do anything without a little bit of music in the background. Clever Keyur is going to come in later and do the scientific side of things because he's the genius in terms of cleverness. But I'm going to just give us a few ideas about why we started with OCULUS. OCULUS is proud, I'm sure, to say that they're 125 years old. I'm proud that we're working with them, but I'd like to also say that we're super proud that Tompkins Knight & Son is 152 years old. So actually OCULUS is really quite a baby in comparison. So today, it's nearly 20 years since we started with the original K3, went to K4, and now working on the fantastic K5. And it's been a revolution of excellence that's come through to us. So this is about the K5, the K5M for magnification and generally giving us a bigger view on things. And it's really how we utilize it within practice at Tompkins Knight & Son Optometrists. there's an overview of our rear beer terrace. Oh, I've said this before. Yes, it's a beer terrace because we like to entertain our patients when they come and see us. And actually, in these COVID times, we are able to kind of spend more time with a patient. We've allocated much more time every single day to every single patient. So the waiting list is kind of longer, but we are enjoying that time to discuss with them. If you want to go and have a look, it's www.tksoptometrists.co.uk, tks-optometrists.co.uk. Come and have a look and see what our ethos is doing. As Sebastian has already and Kai have already said, we're currently still the technology practice of the year because the awards were delayed, but we're waiting to become the contact lens practice of the year. We're in the final, and we can only hope that we can be successful. And with Keyur and our other fantastic colleague, Deborah Grant, we kind of have our basis of a contact lens practice. But that drives our need for dry eye management because our diagnostic suite has very, very successful equipment to analyze many, many things, from the retina with the Daytona and the Triton to the front of the eye with corneal and scleral topographers and axial length for myopia management, with tear lab and inflammatory being an important part of the whole aspect of tear technology. But at the top of that list there is the corneal topographer, the K5 that we're working with. So, yeah, we're going to have, I think, a little bit of a roundtable discussion with Sebastian now. So I will put it to a virtual roundtable because our table currently is square. So I'm going to stop sharing a minute if I can find where that goes. And then Sebastian, you can take back the helm while we continue to now have a discussion.
Yeah, perfect. Thanks for bringing some insight information to us, how your practice or what kind of patients come into your practice. You know that dry eye is a very common disease today. It's not only in Germany, I think the same way in the UK. But still, even today, some practitioners do not really pay attention to dry eye. Why did you decide to make dry eye as an integral part of your routine?
Well, I'll take this question. Kay is going to take some of the others, but ultimately, because we have a long tradition, 1953, I think we started contact lenses in the practice. And as contact lenses became more complicated and more efficient, every single company, and I know there's one or two companies listening in here because I know some of the guys involved in the companies, every single company is still super concerned about dropout. It's modern bucket, leaky hole in the bucket that's dropping lenses out. And I've said this before on stage, and I'm sure some of you have heard it before, but it is rarely ever the contact lens that is the problem with dropout. It is usually the patient because they have a tear film problem, whether it be constituency, volume, mechanical blink action, lid structure, whatever it is. So we started very strongly looking at dry eye management before any contact lens investigation whatsoever. We do not see a contact lens patient until we've done a tear analysis properly and thoroughly. And so it's crucial for making our contact lens success. And we have a very, very low dropout rate. It's kind of almost minimal. It's in low teens. Well, it's not even low teens. It's kind of under 10%. And that's quite a low percentage, I think, for most practices. And it's because we take great care to make sure the dry eye management is there. And when you're talking about contact lens patients, even the standard population of spectacle wearers are more aware with so many Zooms and other webinars going on that they're staring at screens. So it's crucial to investigate.
Yeah, right. So you told us that you are dealing with dry eye historically connected with contact lenses for a very, very long time. How have you experienced the evolution of dry eye testing, and what are the benefits to you as a practitioner on the one hand side, and also on the other hand side for the patients?
So let me know if you can't hear me. I'll take the mask off.
If he takes the mask off, I'll go down
he'll
like
put
that.
the shield.
Because we're not huggable
I
yet.
think it would be good, if you can take the mask off. Yeah, thank you.
So from in terms of evolution, I think the advent of original TFOS and more so TFOS Juice 2 has really brought a wave of information, consensus information about dry eye to the masses. I said there's always been some people like yourself, Sebastian, who've had that interest and have driven it, but you were quite niche. Now it's more common. We now have the internet, which means patients are more aware of symptoms and management options. And ironically, it's the internet that also seems to give them more dry eye as they stare at screens and stare at tablets and local devices. So in terms of evolution, I think as with most things, with time and as more investigation comes along, we're just learning more about it. What's also happening, I can only talk about the UK and actually about the US to a certain extent, is that optometrists as clinicians are getting more skilled. 50 years ago, optometrists in the UK, Brian can attest to this, weren't leaving with quite the same skill set or the optometrists today are leaving. Optometrists today are leaving with a higher skill set theoretically than when I did 20 years ago. Now, with that access to skill set, with the access to the latest technologies, we are now able to manage more within practice without having to push them into secondary or tertiary care. From a practice point of view, if you can make a patient happy, they will stay with you. We have historically dealt with quite a few patients who have been elsewhere and have been fitted with contact lenses and have not managed to get on with them. And come to us, we've done our investigation and they've left, enlightened about what's going on with their eyes, how they are going to be able to help themselves. And we've been able to fit them with a reasonable, a good product to get them where they want to be. And so for patient loyalty, it's huge. And when you have patient loyalty, you are going to drive, we don't talk about this because we're medical people. We don't talk about sales. All right. At the end of the day, we still have to pay the bills, right? Someone's got to pay for the K5. Someone's got to pay for the electricity, the internet, all these things. And loyal patients will come to you to restock on products that actually they could buy online. Amazon is destroying the local market because you Amazon Prime it and it's at your door within an hour, but a loyal patient will always return to you, and we see that a lot. And we have a very special patients who come back to us, and they will buy products from us that are available online.
And actually, a lot of that is driven by education. And of course, the K5 suite of display, as people know that we've been photographing here for 25 or more years, initially slit lamp and all the other technologies. And education plays a massive part in letting the patient be fully aware of what's wrong with them, why they're in trouble, and that helps them be more successful in lens wear or in managing their own dry eye.
So I totally agree with you that only our service makes a difference to products which we can deliver to the patient, as well as other distributional channels through the internet, for example, or the drugstores, for example. So our service makes the difference. Beside your contact lens customers, you have also patients who are coming in probably just for spectacles or maybe for low vision. Do you routinely screen them also for dry eye?
It's interesting. I noticed in your presentation that it was a suggestion that you do that, and I think that's a fantastic idea. A little bit of a sneak. Can we preview what's happening in October? Yeah, okay. Well, basically, we will be spending more time with our patients, full stop, from now on. We're amending our practice model slightly, and everybody will have access to every aspect of our care. At this moment, the way that the K5 is in place and the K4 is in place is their per consulting room. But the diagnostic suite actually, in truth, doesn't have any more room for a piece of equipment. So it's very hard for us to routinely take a spectacle patient and do a K5. But that's not to say that we're not looking at things like tear lab, inflammatory, and also looking at dry eye questionnaires. And as part of our routine questions for a new patient, one of the things that we're keen to get is their sports and hobbies, and then that can drive their workload, and then that can drive whether they happen to have any dry eye symptoms. And a little bit may appear in the presentation a bit later, but we found a massive link between binocular vision issues and dry eye, and one can drive the other, and they're both commensurate with the same symptoms. So we're finding a lot of our standard patients are complaining of dry eye, but actually they may well be suffering binocular vision issues, and we're addressing that in other ways as well.
And sorry, as the person who gets to work in the room without the K5, because Brian's the boss, he gets the new toys. You know, as clinicians, there are certain things we will look for anyway. You know, the K5 is amazing at what it does, but as clinicians, we still need to be able to do the basics, you know, the entry level stuff, and we'd be doing that anyway. And if we felt that they needed the K5 assessment, because we're very lucky the way our model works, we can always arrange for them to be moved through the device, as it were, or get them back for a scheduled dry eye appointment where we spend a full hour with them.
Or more, actually. Last night I had a dry eye patient. It was 2 hours appointment, and that's what's part of our current modelling of fees is that we are not afraid to charge. We're not afraid to spend the time. So most of our dry eye assessments are put in for 2 hours, but we're charging accordingly.
Right. And typically, I can imagine if a patient is visiting your practice and you are caring for this patient 1 or 2 hours, for sure this patient knows after this time, this cannot be for free. This is a valuable effort. And so, yeah, I think this type of service makes us maybe more and more independent from pure product settings, right? Before I would like to ask you something about your typical treatment regime, I would like to ask following. One of the problems with the dry eye treatment is the patient compliance. Depending on the tests which are using, maybe in the different rooms you have, does the JENVIS Pro, which you are using in your examination room, Brian, helping to increase the patient compliance in comparison maybe to the possibilities Keyur is using in his examination room? Can you make an assessment to that question, or is it just...
Now, I understand what you're saying. We find our patients are super compliant anyway. We spend a lot of time during and after the examinations actually discussing, and I go back to the word education. We're educating them about what is wrong. And we frequently find, and I'm sure others get that same thing, people understand much more. They realize that we're kind of dedicated to trying to help them. And the education side of things allows them to understand why they're heat treating, why they are doing blink exercises, why they are... Rarely, we kind of use drops as the last resort. We're much more likely to try and get a holistic approach on education on nutrition and hydration and all the other factors that are there. Yeah. So 1, it makes their lives happier, and 2, it may make their vision better, as you alluded in the blurriness of the vision with dryness, and 3, it makes their contact lenses more successful. So, enabling an educated patient to understand enables compliance.
I think, sorry, Sebastian, to go to your question, although we have 2 different rooms, and I'm not fortunate enough to have a K5, we do have other toys that let us do lots of things, but it involves jumping from A to B to C to A to B to C. And one of the reasons we really love the K5 is you can do pretty much on one machine 95% of what we need to do. And as you spoke about in your presentation about flow and time management, the K5 makes it really easy to do it in one hit. Whereas in my room, I can take images, I can do fluorescein, but you jump from one machine, one database, another machine, another database.
I mean, don't forget he has got a K4, so that has great capabilities anyway. It's just,
Thanks for explaining. And the last two questions I have, maybe Brian, allow me to ask them to Keyur.
in other words,
do you have a favorite treatment regime? And second question in connection to that, is there any state insurance covering the cost for that? As I know that from country to country, there are big differences. In Germany, for example, there are just little reimbursements for eye doctors, no reimbursements in that field for optometrists. So in other countries like the US and so on, there are differences as well. How is it in the UK?
So I'll answer the first question first because that's easy. Everyone really starts off on the same regime because everyone needs the same base. So pretty much irrespective of what type of dry eye they have, we need to make sure that their lids are clean, that their meibomian glands are expressing. So you'll see it in my presentation, the management almost looks exactly the same because everyone needs the same foundations. And unfortunately with dry eye, at the moment, there is no magic pill. So I can't say, take this tablet, go away, 7 days, you'll fix. So a huge one is education. So we educate them about nutrition, about diet, hydration, but everyone starts off with warm compresses, lid hygiene, artificial tears as and when. Then as we step up, we're fortunate enough to have an IPL. So that's intense pulse light treatment for those who don't know the abbreviation. And that is, we've had really positive results with that. And we've seen across the industry that it has very positive results, regardless of whose machine you're using. So we will step that up. We try to do it as a staged management, because if you Hail Mary everything, if you throw everything at it, you actually then don't know what has worked and what hasn't worked. Because I'm fortunate enough to have done the independent prescribing course, I can do oral antibiotics for the meibomian gland dysfunction. I can do the topical steroids for discomfort. I can go as far as doing JENVIS, which is the cyclosporine-based non-steroidal drug, but it is extremely expensive if you were to pay for it privately.
And because he's my friend, I get all those too. That's the nice thing.
And this is covered or not covered by the state insurance?
Not within. So within the optometry, within our model, the way we practice, it's not covered. But for this level of care, they would have to go within a hospital setting to see ophthalmology. And only then would they get to JENVIS if the consultant felt they were really at that, tail end of management. Hospitals, as far as I know, in the UK are not offering IPL at the moment. No hospitals that I know of are offering IPL. Even with artificial tears, because the NHS is so stretched, there are some regions which won't put artificial tears on repeat prescription now. They will give you the one-off and then say, right, you need to self-pay. So our health service is stretched and not been helped by COVID, where they've had to reallocate funds to help with the crisis that we're sitting in.
For giving us this overview and for the nice discussion. And I think at this point, we would be quite happy if we can see some of your recent case reports. Okay. Which type of cases you have in your daily clinic. And so we are looking forward to see that. So do you have the screen share option in your hands?
Give the
Right
screen
now?
tip back to me.
You can share contact, you've got it.
Brian, you're now the presenter.
Yep, there we go. We're good.
We're good. And then I
Perfect.
just need to hang on a sec and I'll get it back into place. So we've done the virtual round table and now we're going to go into case history stuff. So I'm going to leave that partly wire topography. We've kind of answered this already, but we have been fitting lenses since the 50s using the ophthalmometer you can see in the picture. 20 years ago, we took on the K3, 4, 5, etc. And we know that the repeatability of those instruments is there for us. And as I said, despite dropout, despite improvement in fantastic materials, dropout is still occurring. So it's down to that person. So I'm going to let Keyur speak for a time now, and I'll see you in a minute.
So quickly, it is ironic. You mentioned, Sebastian, that contact lenses cause dry eye. But if you look down, do you use, I think it's stage 4, to manage dry eye, use contact lenses. So it's a bit of a dichotomy, contact lenses, and we fit a lot of them. So what you need to remember is that the K5, above all, is still a topographer. And I think sometimes we get so caught up in the magic of the new stuff, we forget how good it is and what it was initially designed for. So I'm started off with the cases, and we're going to go a couple of different scenarios. So this is case 1. And we had a 55-year-old lady, and she was just unhappy with the contact lenses. She didn't like wearing her glasses, and she wanted to wear them minimal. Now, she had a minimal refraction, I would say, and the significant portion of her refraction was reading. Nothing really, anything else of interest to talk about. Now, the interesting thing was that she'd been fitted by another practice, I don't know who, with Alcon's Dailies Total 1 multifocal. And I don't know who knows this product, but it's a fantastic product. We use it a lot. It's our go-to product, particularly with the dry eye patients. Brian wears it, Mrs. Tompkins wears it. And you know that if an optometrist is wearing a product, that it's got to be good, because we've seen through the hype that all the marketing can kick through. So I'm kind of sitting there thinking, well, what's the problem if she can't wear these? So the first thing we did is we did topography. And you look at the topography and you're sitting there thinking, well, that's all red. And then you look at the case and you realize how steep she is. And so that, I think, was a big part of the problem. She's got a steep cornea in a lens that's fantastic material, but designed for 95% of the populace. And I just don't think that it was fitting very well. The optics are not going to be great. The alignment's not going to be great. That's just the different, same scan, different view, tangential curvature. And so the symptoms she was describing, we thought, right, well, let's go through and do the dry eye assessment as well while she's here as part of the thing. And you've covered this, Sebastian, so I don't want to spend too much time on it. But you can see there, predominantly, everything looks okay. So the meibomian glands are not perfect, but they're by no means the worst. A little bit of conjunctival staining, non-invasive tear belt is pretty good. So blink completeness is not great, but not too bad. I mean, I think anyone who'd look at that would not look at that and go, oh, that's a raging dry eye issue. So it made me reassess that we were probably more of a lens issue. So the nice thing about the K5 is it does pupillometry, and it does it in a fantastic way where it flashes lights. And it gave us the data that we needed, mesopic and scotopic pupil sizes. And what I decided to do was we gave her a tentative diagnosis of mixed dry eye. And as Brian alluded to, we're seeing a lot more people with binocular vision issues complaining of dry eye symptoms. And there are a couple of nice papers out there showing the correlation between OSDI and CISS or CESS, I can't remember which one. It's must be CI, convergent insufficiency study, and showing that they're having dry eye symptoms. So we discussed nutrition, we discussed hydration, we did blink training for her. So we spoke to her about every 30 seconds, making sure you do a 30-second blink, taking time away. We discussed all the things we've spoken about, so I'm not going to prolong that too long. And then we went with a synergized duet progressive. So essentially a hybrid lens with a rigid gas permeable center and a soft skirt. So best of both worlds. In all honesty, I'm waiting for that to arrive. This patient I saw 5 days ago. So once it comes in, I'll be able to give you an update. But now what's really good about all of the data is we just do empirical fitting. So you don't even have to worry about putting anything on the eye. So I think that's a good way to start, just to say, look, don't forget topography. It's very easy to throw on a soft lens and go, that works. But when it doesn't work, you've got to be able to figure out why it's not working.
And don't forget that there are many multifocals where you can actually topography over the lens itself and see centration. So there are many functions of topography within practice that are perhaps overlooked at times.
Yeah. So Sebastian, you've destroyed my presentation with yours. A lot of this is covered, so I'm not even going to talk about it. I'm just going to scroll through it because I'm aware we're a bit getting close to the 12:30 mark. And I did a lot of what you did. You know, it does the questionnaire, fantastic, nice tick. It does the non-invasive breakup, and I'll just give it a couple of seconds and you can just watch that. I screenshotted how it actually works. You know, this is great education. The patients love it. It's a show. They see, they can really grasp what is happening and where it's happening. And it doesn't take long to go through that with them. The one thing it doesn't do yet is osmolarity. So I don't know if you guys have that in the plan, you know, in the pipeline. I know you can record it, but, you know, German magicians maybe be able to find a way of figuring that out, how we can pull that non-invasively would be amazing. Conjunctival staining with the grading scales. You know, I don't even have to think about it. I just drag the image to the appropriate scale, and to make it short, you can see all the different tabs for the different things that you can grade in one hit, which is fantastic. Mybography. So this was a big one for us. You know, we didn't really want to invest in just a mybographer, and we had been using our OCT off-label with the anterior seg unit to take OCT. And we were getting reasonable results, but nothing as good as this. But again, the grading is there. Okay, so you've got that tear meniscus height. Sebastian showed you guys how to do it, how it works. But this for us is the winner. This really lets us educate our patient, and you can see there. And it, you know, even now as I look at it, it impresses me at how cool it looks. And if I can be impressed as a practitioner after all these years, your patients will be blown away. Okay. It also makes it easier to explain what's going on. So I'm going to quickly jump onto case 2. This lady had presented with, she had called us during lockdown, and she'd had complaints of that she wasn't happy with the distance vision in her contact lenses. She wasn't happy with the near vision in her contact lenses. She was a full-time contact lens wearer. We did a refraction, came up as slightly myopic with an early ad, so early presbyope. Mybography shows that she's starting to have issues here, and that's going to contribute to her problems. And can you see the video? Is it playing for you guys? Yeah. And you can just see that. And this is always fantastic because sometimes as practitioners, it's easily overlooked. But you can see those incomplete blinks that she has. And the K5 demonstrates it so well. And to be able to record it, you can then demonstrate it to the patient, which is fantastic. So for her, we were able to generate a report. And you can just look at it. And like you said, Sebastian, it's easy for the patient to understand. They sit there, they look at it, they understand red is bad, green is good, and yellow is somewhere in between. Or areas we can work on, I should say. So we fly through that, and again, evaporative dry eye, right? Basic building blocks of dry eye management, nutrition, hydration, with this patient blink training. And again, we discussed IPL. We talked about the lid hygiene, the warm compresses, and the ongoing management, the need for ongoing management. For this lady, we tried 2 different products. because the topographies were relatively normal. We went with the Dailies Total One multifocal. Again, we like it; it works. And the other product we've been really impressed with is the SafiLens Fusion multifocal. Fantastic product. Works in a different way, so it just gives us a different option. But when you pull all this data together and you educate your patients are sitting there going, well, I've never had this done before. No one's ever showed me this. And the point we were talking about earlier, Sebastian, about patient compliance, is it's better if they understand the problem. A lot of what we talk about can be quite obscure to a patient. We talk about blepharitis, a nice Latin term, which we know about because we went to optometry school, but the patient, it's just an obscure term for them. It's out of the way. Interesting one here is case 3. So this is slightly different. And again, I'll fly through this. So this patient had long-standing dry eye and actually wanted to see us for a scleral lens fitting. Was their first reason they contacted us. Now this guy had the works. We were talking punctal plugs, LipiFlow, IPL was on Icavis. Refraction, pretty close to 0, but with a reading at. So I'm not going to go through the testing again, but this is his report. And you kind of look at it, and you guys have seen 3 of these now, and I mean, that's how easy it is to analyze. OSDI, inflammatory, not good, but pretty much everything else was in the green. All right. So you've got some MGD loss, but you've got significant symptoms and positive MMP9. So with this patient, we had to go along the lines of neuropathic diagnoses within their treatment. So again, even with the neuropathic guys and neurotrophic guys, they have to have the basics first. What we have seen with the neuropathic patients and the neurotrophic patients is there is a lot of element of psychosomatic within that. And these guys usually need to be managed in conjunction with their GP. A lot of them need systemic pain medicine or need to be referred into pain management clinics, because what we are seeing doesn't correspond to what they're reporting. And now we know there's an issue with OSDI and symptomology and dry eye in general. This patient actually had gone to Moorfields to have the corneal nerve endings imaged, and he was told that the nerves were fine. So we know that he is beyond just it being ocular surface. And at this stage, we have to start talking about co-management. Unfortunately, with this patient, we tried the Dailies Total One, and it didn't work. So he's going to return for a scleral lens fit. And part of what we think may happen is there's the psychosomatic element of having the lens will hopefully make them feel better. The more dry eye you do, the more you will realize you become a bit of a therapist. And these patients do consume your time. And so you have to be aware of that. You have to factor that in. If you're going to do dry eye part-time and not make sure you're reimbursed accordingly, you will run at a loss, is what I have to say. And you really want to factor that in. These guys are complicated. They've been to lots of other people. The simple stuff is simple, but the complicated stuff does get complicated. This I want to hand back to Brian.
Yeah, and that's kind of where I want to try and give you the idea of another case, but this is the business case. There's the business owner with co-directors. We have to make the practice run. We want to make sure that the management of fees is as good as the management of the dry eye or the contact lens. So post-COVID, I think we're all extending the time, as I said earlier. So dry eye shouldn't be failing you and your patients. You've got the tools to work with it and make your practice stand out as a USP amongst colleagues in the locality. And as we've done one discussion about fitting empirically, this is the kind of eye you want to fit in an empirical way now. So the K5 is useful for us to do any of our more complicated fitting, because otherwise you fit badly and that fit might come back and bite you. because to me that looks like the evil eye of a superhero in some way, shape, or form. So success comes with investment in time, in equipment, and certainly our investment in that K5 has been an absolutely superb success. So we're going to sign off and go to further questions. I think we're just about right on timing. Vielen Dank. Thank you very much. Good day, and thank you to those that are listening in various parts of the world. So that's us signing off to thank you from both of us.
Ever so quickly, I'm really sorry because we had the flow done, but I just saw something on social media the other day that there's been a study that wearing your mask makes dry eye drier. So if anything, you've got people sitting at home on screens more. They're wearing their mask. Dry eye, the market is there to really take advantage of that to improve your businesses.
And what's interesting is, will a shield actually bring a nice environment? You breathe out and you're getting nice fumes into the eye. That's a further study, Sebastian. You can do that one. I'm going to stop sharing now so you guys can take over and do what you need to do.
All right. Thank you very much, Brian and Keyur, at first. Thanks for that very, very interesting insights you gave us. There are a couple of questions which I summarized, and I would like to share this with the panelists. The first one will be if the patient have dry eye, for example. Which parameters are you going to look at before they will be maybe forwarded to cataract surgery?
We currently work with a surgeon, one of the best in the world in our belief. He's not local to us, but he's not far enough to be a problem. He's pretty much making every patient that's having cataract surgery go through IPL. Now, at this moment, we're not either funded or managing their dry eye, unless they're one of ours already. We sometimes see patients he lets us do IPL with because they're local to us. But some of our patients, we're kind of making sure they're okay, but we're kind of jumping to IPL first, unless you've got any other experience.
No, I think the thinking now, and it has been for a while, is that you want good refractive surgery, then you want the best data, good tear film, non-dry eye. We also know now that even with cataract surgery, dry eye surgery can be worse post-surgically. So you want and you don't want someone seeing 6/6 but can't deal with the pain as we've seen in other forms of refractive surgery. So I think particularly the guys who are doing it privately are really pushing for the best ocular surface before they do anything.
So
that's right. So that's true. So I mean, they have a passion for doing, of course, to give the best anterior surface to the patient before applying any type of restrictive cataract surgery. That's also of our knowledge, as we recognize from all of our machines we provide. So there's another one. So for example, if you, in your experience, did OCULUS, especially the K5, changed your treatment plans in your office? So for example, do you earlier or change the treatment like artificial tears quite much more often than if you, for example, wouldn't have had used the device?
I think it's giving us a much, much better insight as to what may be going wrong. And with greater insight, we get more accurate first-time treatment. I think that's probably true to say.
Yeah.
So we're not trying trying kind of management methods that are unlikely to work. So evaporative methods of management, if it's aqueous, and the other way around. So I think it's a much more targeted approach. Any diagnostic tool that we use allows us to investigate and treat, and that's the education word. So I think it's giving us a greater insight to allow treatment to be more efficient.
Yes, thank you very much. Sebastian, do you have any further suggestions which you want to add at this point?
I think it was a good last case report presented by Brian, that if you start caring about dry eye patients, first of all, you will attract all the standard cases, but if you are attracting more and more standard cases, you will also attract the special ones, which are more complicated, and they, of course, take more time. And sometimes expectations are very high, and we need to inform our patients that we cannot create miracles. So we are only cooking water, but motivation on the one hand side, in comparison, in combination with a very good treatment, may here the option to reduce the symptoms as good as possible. But as Brian said, dry eye is a chronic disease, so we cannot heal it. Those people are popping up from time to time, and you need to have a very good management how to deal with the special cases and how you charge the fees.
Yeah. What we do find is that the very severe dry eye patients and the very severe complex contact lens patients probably will know each other through at least one or two of the Facebook or internet groups. And so if you get, which we hope to get, a success story with one of them, many of their friends follow. And we get people traveling these days from very large distances to come and see us. And I think we have to perform well in their eyes, partly to cure their issues, but partly to justify why they've traveled so far. And so far, the K5 has added to that absolute enhancement of the diagnosis and the education. So it's been a durable process using it.
Yes. With that said, I want to really thank the panelists, especially you guys, Brian, Keyur, and also Sebastian. It was a pleasure. I love this webinar. We want to thank you, also our participants. And if you still have some questions regarding that, please feel free to send us over your questions. We will come back to you. And I wish you all the best for the forthcoming Weird Structures Days. And we thank you for participating. And I want to say goodbye.
Yeah, we're very happy that you tag onto our social media profiles. So look at BT Optom, and Optomegeek. So look at both of those. Look at TKS Optometrists, and ultimately we're happy to answer private questions, and we're really happy to connect with the people who are really interested in proper dry eye management.
All right. Thank you very much, and stay safe.
Thank you. Bye-bye.
Bye-bye.
Wiedersehen.